And today, inshallah, we'll be speaking about supraventricular tachycardia. Okay, so we'll have a brief introduction, then we'll have also a brief discussion about the general mechanism of arrhythmias. And then we'll go along the types and approach to SVTs in general. And then after that, we'll have an interactive discussions and ECG cases that include the SVTs. So to start with the SVTs, it's a most common type of arrhythmia that we encounter in the hospital, including its different types, starting from the AVNRT, AFib, and all the other types that we're going to see. And from the terminology, it's supraventricular tachycardia, so it's always require an atrial or atrioventricular tissue to start its tachycardia or to originate the tachycardia from. And since the name tachycardia, so the rate is most of the time above 100, or it's always above 100. And it kind of has most of it has an abrupt onset and offset, and as we're going to see, except of some of their types, and this is because of the mechanism of its generation. And again, it's basically an autocomplex, usually less than 120, except if we have some cases if we have an aberrant conduction, or if we have a baseline ventral branch block as well. So speaking about the mechanism of arrhythmias in general, so all arrhythmias fall under three categories of mechanism. So the first one is abnormal automaticity, meaning that having automatic impulse, that generation from unusual side, like in cases of atrial tissue, like atrial tachycardia. So the atrial tissue in its normal situation doesn't generate impulse. But in case of arrhythmias like atrial tachycardia, so it takes over the impulses from the sinus node and start generating at a high rate of tachycardia. And the second mechanism, triggered activity, which is a problem in the action potential or depolarization, which is secondary depolarization during or after the depolarization. And example of that, like long QT and torsades pod. And some types of atrial tachycardia here, we're speaking about the SVTs. And the last most common mechanism, which is a reentry, and this is the most common type, and majority of the SVTs fall below this category. So for reentry tachycardia, usually to have a reentry, we need to have a circuit, and the circuit to start the tachycardia or the arrhythmia, it has to have two limbs of the circuits. And these two limbs has to have a different refractory period. So one limb has to have a longer refractory period than the other one. And at the same time also, they have to have discrepancies in the speed of conduction. So one will have a slow conduction and the other one will have faster conduction. And these mechanisms also can give you a clue about the tachycardia itself. So usually the reentry tachycardia has an abrupt onset and abrupt offset, like the AVNRT, for example. So it stops immediately and starts immediately, doesn't slow down, like in cases of atrial tachycardia, for example. So the heart rate starts going gradually up, and then when it stops, to go gradually down. So this is an example of abnormal automaticity. These are the types of SVTs, atrial flutter, atrial fibrillation, atrial tachycardia, and all other types. We will go over them one by one and have examples for all of it. So to start with the first ECG for today, who's going to interpret this ECG? From the candidate, please.
Okay, I can take it.
Okay, go ahead.
Okay, so this is a narrow-complex tachycardia.
Okay.
I cannot see a clear B wave, but there is a pseudo R wave in V1. And also there is electrical alternance.
Okay. So
this
yes.
This go with AVNRT.
Try to have a closer look في V1 and these arrows, the blue arrows, these points toward what? Is there, try to figure out any B wave. Is there, look at
yes,
here.
after and it is pseudo R wave.
Yeah, pseudo R usually comes here immediately here, right?
Yes, في واحدة فيها there is one and the other is يعني the second beat there is a pseudo R wave or the third one.
This is retrograde B wave.
Okay, so what do you think about this? الارو هنا. This is mostly B wave.
It is yes, B wave. It is long RP arrhythmia.
No problem. We will go through all of this, RB definition, long or short. Okay, as you said, this is narrow complex tachycardia, electrical alternance, and there are B waves here, very subtle B wave, easily can be missed. And here, and here, and here. And these B wave are upward, it's not down. Usually in V1, we have it downwards. So this is most likely the retrograde or reciprocal activation of the SA node. So we have an up wave. So this is still short RP because it's less than 50 and less than half of RR. And the diagnosis is most likely, the final diagnosis. Which form of tachycardia? AVRT. We will see why, and we will go through all of this and we'll see it again. So in AV reentry tachycardia and AVART, usually, as we said, it is the reentry tachycardia. So we must have a circuit. So in this case, we have a circuit here, the normal physiological track, which is the AV node and then goes down to bundle of His. And we have here accessory pathway. Okay, so we must have two circuits to run the tachycardia. And if we see here, this is again the sinus wave, and this is how it goes. Start from the sinus beat, the activity goes down through the His, and then again here accessory pathway, which conduct again the impulse through the ventricle. So which generate fusion activation of the ventricle. So the ventricle gets activated from the AV node and through the accessory pathway, and that's reflect on the 12 lead ECG as a delta. Of course, the accessory pathway is not like the AV node. So the AV node has the power or the function to slow down and to go through a certain speed. So it has a speed to function through that. So it will be like arranged conduction. But here in accessory pathway, it goes very rapid, doesn't have this function of here. So that's why it comes earlier here, and it generates what we call a delta wave or re-excitation in the ECG. And this is again the other example. So the accessory pathway, it can conduct in two ways. Like what we saw a while ago, this is an antigrade. So if we have here impulse coming from up, from sinus node, for example, and that goes down to the AV node and goes down through the accessory pathway, and that reflects on the ECG as a delta wave, or what we call manifest delta or manifest accessory pathway, because it manifests in the ECG as a delta wave. While here in the other situation, it's still again it's an AVRT, but the accessory pathway here does not conduct in the antigrade direction. It only conducts through the retrograde conduction. So once we have here impulse generation from the sinus node, goes here to the accessory pathway. It's try to activate the accessory pathway, then the accessory pathway will not activate and will be in refractory period. And then, so the impulse will find its way through the AV nodes and go down to bundle of His. And that's why we will not be able, in the case of the sinus, this is in the case of sinus rhythm, not the tachycardia. So we will not be able to see any delta wave or any accessory pathway here. And this is called concealed accessory pathway. So what we have explained now, this is in case of sinus rhythm. So this is sinus beat. In case of the tachycardia, so what happens in the tachycardia? Usually the tachycardia AVRT gets started with the PAC. So in this case here, PAC starts, come down here to the AV node, okay? And remember that the accessory pathway is in the refractory period from the previous sinus. And sometimes it cannot conduct in two ways or in antegrade. So the BACs goes down to the AV node and then go down to bundle of His. And then when it comes down here, the refractory period has already finished here or terminated in this accessory pathway. And it goes back the way through the accessory pathway to the atrium. And then from there, take the circle again and start generating a tachycardia AVRT. And this is what's called orthodromic AVRT. And in this case, you would expect the QRS to be narrow, not wide, because the conduction to the ventricle was through the normal process. So through the normal AV node, we don't have an impulse going down the way here. So you don't expect to have a wide QRS. While in the other situation, in the antidromic SVT, again, the tachycardia start with the premature atrial contraction. And then here, the accessory pathway can conduct through this pathway, through the accessory pathway. And usually, as we said, it must have a different refractory period. So one has to have a long refractory period and other one has to have shorter refractory period. So in this case, let's assume that this is longer refractory period and this is shorter refractory period. So when you have a BAC meaning that it comes premature, it comes early. So when it comes down here, still the AV node is still in the refractory period. So from the left atrium, it's going to go through the accessory pathway, and it goes the whole way down up to the ventricle, and by that time, the refractory period terminated in the AV node. So it goes back again through the AV node, and then the circuit starts generating again and again and again. And in this way, we expect it to be a wide complex tachycardia because the conduction from the atrium to the ventricle was through the accessory pathway, not through the physiological AV node. So this is again just repetition of what we said. So look at this sinus rhythm. So there is a difference when you see in the sinus rhythm and tachycardia. Here, just to compare for you. So this is what we said, the orthodromic tachycardia. So in the orthodromic tachycardia, at the sinus rhythm, you might have a delta wave at the sinus rhythm. Okay, so let's see here this accessory pathway, for example. From this, we can say that it has two directional. This accessory pathway can conduct downgrade, antigrade, or retrograde. And how can you say that? From the delta wave. Because in the sinus rhythm, you have not the BAC, so you have here from the sinus node, it goes down the way here, through the AV node and through the accessory pathway and generate for you a delta wave. So from this baseline ECG, you know that this accessory pathway can conduct in both ways, not only as we say here in retrograde. Okay, so once that happened in the sinus tachycardia, then a PAC started here, and this is what's represented here in this figure. So PAC started. When it comes here, it's still in the refractory period. And as he mentioned here, a longer refractory period, and these have shorter refractory period. So it goes down through the AV node, as we said again, and then back again, and the circuits start again. Notice here the baseline was wide QRS, while here narrow QRS. So the baseline was wide, but when tachycardia started, it becomes a narrow QRS. While in case of antidrom, yes? Right. In case of antidromic tachycardia, so here the accessory pathway conduct during the sinus rhythm. So we have a delta wave here. Okay, and again it conduct in the tachycardia. So we have a BAC here, again with the same way, it conduct here down, goes up to the AV node, and the circuit start again and again. So, and here, if you see the B wave, and we will come at the end to the approach of SVT to how to determine the RB and the PR segment. So when we say short RB or long RB, we take the RR and make it a half. So 50% like from this. So if the B is before half of the RR, so this is short RB. Okay, and then short RB can be AV-NRT or VRT, and we will see that as we go along with the presentation. طيب, who will take this ECG?
Yes, I am.
Okay, تفضلي.
It's a narrow complex tachycardia.
Okay.
Heartbeat about 160.
Mm-hmm.
There is left axis.
Mm-hmm. What type of narrow tachycardia?
There is no obvious P wave or retrogradely conducted P wave.
Okay.
Most likely it is AV-NRT tachycardia.
AV-NRT tachycardia. Okay. Fine. Good. So yes, it is AV-NRT tachycardia, but the axis here is normal axis. طيب. AV-NRT here, arrow, what is pointing to this arrow? These things. This is what a while ago Dr. Mohammed said. This is pseudo R. So this is pseudo R.
Pseudo R wave in V1. Pseudo F wave.
Yes, exactly. So this is pseudo R. It's immediately after the Q and then R.
Indicating retrogradely conducted P wave.
Yes, exactly. Indicating retrograde conducted P and AV-NRT. So in the AV-NRT, again, the circuit here, it's the same reentry tachycardia with the same concept of AV-RT, but here the circuit is inside the AV node itself. So it's almost the same concept that happening in the AV-RT, just here, like we can call it a micro circuit. So it's something small inside the AV node. Again, the AV node has two circuit or pathway. Sorry, mouse. Has a two pathway. It has the slow and fast pathway. Just 1 minute. Okay, so it has the slow and fast circuits or pathway. So in the normal sinus rhythm, in normal AV node, when the impulse generates and comes down the way to the AV node, it goes through the fast and slow. By the time it reaches here, conduct down, and then the fast immediately go into refractory period. And by the time the slow pathway comes down the way here, it will find this fast pathway in already refractory period, so it will abort itself and it will not be conducting down. So it's going through the fast pathway and then goes down to the ventricle, while the slow being stopped here by the refractory period of the fast pathway. So what happened in the AV-NRT? In AV-NRT, this is what we said in the normal sinus rhythm. In the AV-NRT, what comes usually started with the PAC, premature atrial contraction. And then when it comes down here, find this is already in refractory period. So when it comes to the fast pathway, it will be in refractory period. So it's going to go through the slow pathway down, and then it reach here up to the ventricle. And by the time it comes here, the refractory period is already terminated for the fast pathway, and then it goes back through the fast pathway and then reactivate the atrium up or the atrium, and then go back again as a circuit in the AV node microcircuit tachycardia. So this is what we were explaining again here, the similar idea. And this is what we can see in the ECG. You have a pseudo S in the inferior leads, lead 2 and lead 3. You have pseudo R in V1, which is retrograde B wave. Sometimes, very rarely, you have also pseudo Q. If you can arrange it according to the community and coming in the ECG. So we have the first one, absence of B wave. So most of the time you don't see B wave at all. And this is like 60% of the time. You don't see B wave, you don't see retrograde, and you don't see either R or Q. Okay. And then in 30% of the cases, you see the pseudo S or pseudo R. And in only 4% you can see the pseudo Q wave. Again, here, what we can see, the B wave is a little bit away from the QRS. This is in case of atypical AV-NRT, but look like the AV-RT. And why it is like that, taking a space from the QRS? Because in case of atypical AV-NRT,
the conduction through the...
Yes, the back conduction is through the slow pathway. So it conducts down through the fast pathway, and when it goes back, go through the slow pathway, and that's why it takes time for the B here to appear in the ECG. So just again, as you said, this is pseudo R and this is AV-NRT. We'll take this ECG from the next arrhythmia. دكتور أشواق، إيمان، حميد وحسن. ده big names ولا دكتور أشواق؟
nerve complex tachycardia.
Okay.
No obvious P wave. There is pseudo R in V1.
Okay. Try to look closer for the B. Can you elaborate any P wave? طبعا to look at the B wave, usually the best leads to look at V1 and lead 2. These are the best for the B wave. Here, what arrow points? What are these? Could it be B wave, Elena? These.
There is P wave in V1.
أيوة. So these are the B waves, صح?
The RP longer than PR.
RP longer, so long RP tachycardia, okay.
Long RP tachycardia. It could be sinus tachycardia.
Sinus.
Atrial tachycardia.
Or atrial. طيب, you think
or
about
atypical AV NRT.
تمام. طيب, atypical AV NRT is still short RP tachycardia. It's not long. Yes, it is longer. RP, yes, it's longer than 60, لكن it's still in the short RP. لكن صح, you said sinus or مثلا atrial tachycardia. So what do you think, هنا atrial ولا sinus tachycardia? البي wave هنا, does it look sinus? البي is up sloping here, صح? It's up.
Sloping in B1, not.
Yes, it's
not
up
sinus.
in B1, most likely not sinus, صح?
Not sinus.
Try to localize it again in inferior here, لكن it's not clear. Here maybe it's downgrade, لكن it's not very clear في inferior leads. خلاص, ولكن here it's up in the V1. This is not typical of sinus. الساينس عادة بتكون either negative or biphasic. So this is, as you said, exactly atrial tachycardia.
Atrial tachycardia.
Yes. So atrial tachycardia, it is a different mechanism from the previous. It is most of the time abnormal automaticity. So we have an atrial tissue that generates an impulses and then conduct through the AV node. Atrial tachycardia, most of the time it's rapid, but it rarely exceeds 200. And it's relatively regular. Sometimes you might see a slight irregularity. and mechanism, as we said, abnormal automaticity most of the time. And mostly the foci of the atrial tachycardia, the most commonly area is the pulmonary vein in the left atrium or crista terminalis in the right atrium. And the causes for atrial tachycardia is most of the time it's lung, like obstructive lung disease, electrolytes, sometimes drug, and in less common cases you find cardiomyopathy or ischemic heart disease. So in atrial tachycardia, when we localize the B wave, you always look at the B axis. Look at the B axis, meaning that looking at V1 and inferior lead to localize the morphology of the B. Sometimes if the focus is from the right atrium, it's deceiving. It looks sometimes exactly like the sinus, especially if the focus is very near to the sinus node. Here it's negative in sinus. And look at here, because of the impulse coming from the right atrium, so near from the sinus, still it's negative. So you might be deceived by this. Okay, but here sometimes, again, same like the sinus. So look at the other leads. If it's V1 is negative and you have high suspicion of atrial, look at inferior leads. You might find it either isoelectric or negative. While in the left atrial, if the focus from the left atrial, this is most of the time clear. You have a positive B wave in V1, okay, and negative in inferior leads. And this is as we had in our case here. كانت البي wave في ال ECG هنا was positive. So this is most likely a focus coming from the left atrium. And then this is again the RB. طبعا we'll have في approach at the end, we'll talk about this RB. Just to go here quickly, the RB interval, usually في atrial tachycardia, it might be variable, especially if you have more than focus of atrial tachycardia. Sometimes you have two focuses of atrial tachycardia. So you will have a variety of the RB. And usually it's long RB, that's why RB is longer than PR. And the heart rate usually around 150, it rarely exceeds 200. And one of the hints also to differentiate between, sometimes it's very difficult in ER, you just have a tachycardia neurocomplex and you cannot differentiate. If you give adenosine, for example, you would find it slow down gradually and then again back to tachycardia. So this is less likely to be a reentry. Reentry tachycardia usually either stops or does not respond. So if you give verapamil or adenosine, for example, and the tachycardia stops immediately, so you think of anything that's as a cause of reentry tachycardia, like AVRT, AVNRT. But if the heart rate slows down gradually and then goes back, yani partial response, at this time you can think of atrial tachycardia as the most common. طيب, this is again another ECG. Dr. Adam. Or Dr. Ayman.
Assalamu alaikum. Yes, this is neurocomplex tachycardia. There is different B wave with different shape.
Okay.
And irregular neurocomplex tachycardia.
Yes. So what will be your diagnosis?
Multifocal atrial tachycardia.
Multifocal atrial tachycardia, correct. تمام. Excellent. طيب, as you said, إنه عندنا هنا multiple more than 3 B wave morphology. We have one here, we have one here, we have one here, and one here retrograde. So we have more than 3 with no dominant B wave. So there is no B wave that take over most of the rhythm. And as I said, multifocal atrial tachycardia. It is almost similar like atrial tachycardia, just the difference here we have more than one focus. So again, it's abnormal automaticity. As we said, we have more than 3 consecutive B wave with different morphology. Rate again around from 150 to 200, rarely exceeded 200. And a BB interval, BR interval, and RR, it's most of the time, it's variable because we have 3 focus. Everyone has its own characteristics. And the differentiation between other tachycardia that you see a clear baseline, isoelectrical baseline between that. And the mostly seen in cases of COPD and electrolyte abnormalities. طيب next ECG دكتور حميد. ودكتور معاوية.
Okay. This is
yeah.
Tachycardia.
Okay.
That seems a little bit wide.
Slightly. يعني still in that يعني.
Heart rate of around 150.
Heart rate 150.
If we look to the inferior lead.
Okay. think disconnected دكتور معايا ولا؟ اوكي طيب he was saying انه narrow complex تقريبا يعني a little bit 120 here and inferior lead if you can see here we don't have an isoelectric line and we have what we call sawtooth appearance. We have a negative deflection here and here and here.
Flutter with 2 to 1.
Yes, if you see here,
clockwise.
Yes, you see P wave
with variable block.
Clockwise, flutter with 2 to 1.
Yes, yeah, I mean, this is variable. Most of the time 2 to 1, except here. We have almost 3 to 1. 1, 2, 3. So variable every block, exactly. So this is atrial flutter with variable every block. And as you said, this is typical, which is counterclockwise. Atrial flutter, again, it's the re-entry tachycardia. Again, meaning once you enter, once you hear the terminology of re-entry, that's meaning it's abrupt, onset and offset. The circuit here in the atrial flutter most of the time or بيكون في tricuspid valve or the cavo isthmus re-entry circuit. The length of the circuit itself depends on the atrium, right atrium. So if you have a dilated right atrium, you might find a little bit slowish heart rate. If you might have a normal right atrium, most of the time you find the heart rate around 300. And once you see the heart atrial rate of 300, always be suspicious of atrial tachycardia, even though that it's not a typical sawtooth appearance, because it's actually one of the tricky tachycardia. Sometimes you look at the ECG, you expect that to be atrial tachycardia or even sometimes sinus. And when we go to the AB lab and do AB study, you find it as Flutter. So it's not, especially the atypical part. So always you see a 300 BP rate of 300, make a suspicion of atrial flutter as the top of the list. So as we said, 300 the AA, but usually the AV node are not able to conduct with this rapid conduction. So most of the time is accompanied by block, AV block. And the commonest type is 2 to 1 AV block. So as we said here, typical flutter and atypical. Typical usually have the direction of the circuit is the counterclockwise. Okay. And atypical is usually the clockwise. The typical is usually you see in the sawtooth or fluttering wave, negative in the inferior leads, and positive B wave in B1. Atypical, it doesn't have really something specified. And they said positive, but most of the time it's not specific. You just see, sometimes you even see isoelectric line. in some cases in atypical. So it's always tricky, the atypical flutter. But once you said the atrial rate 300, as we said, either in here, suspect atrial flutter. So whenever you see an B2B 1 box or 300, suspect atrial flutter. So this is again the same ECG as we said, atrial flutter. The next is atrial fibrillation. Of course, this is one of the very common or commonest one that we see in our practice. It's include for almost 30% of arrhythmia related in hospitalized patients. Atrial fibrillation it's usually easy to diagnose, but again, easily to miss also, especially when we have coarse atrial fibrillation. So in cases of fine atrial fibrillation, you usually see irregular, and you label with no B wave, and you say, this is atrial fibrillation. But a lot of time you see a fibrillatory wave that are coarse and that conceive you, and you're thinking that is B wave. So you look at this and say, this is atrial tachycardia, for example, with a 3-to-1 block or 2-to-1 block. But you have to look carefully and have to analyze all the leads. So if you have seen something like that, especially if it's irregular, so you have to look to all the leads, not only one lead, to confirm your diagnosis. This is just a brief about each type of the SVT. Again, when you look at the ECG, narrow complex ECG, you have to put an approach in your mind to follow, not to miss anything, or not to be confused. Sometimes you find an ECG that is very, when you look at it the first time, it will be a very difficult, and you'll be shocked and you'll be stubborn. But if you have an approach for the, especially say narrow complex, for example, so you have put in your mind 3 questions. Is it a narrow complex or a wide complex tachycardia? So if you're talking about narrow complex tachycardia, so try to look at the B wave. Again, if it's wide complex tachycardia, again, still it could be SVT. So it has its own approach to differentiate it between the ventricular tachycardia, and that's a different topic, might be covered in another session. If you look at the tachycardia and then you think this is SVT, the next thing is look at the B wave. Try to localize the B wave, because usually in this tachycardia, the B wave is not very clear and usually it's tricky. Sometimes you find it hidden in the T wave. Sometimes you find it just close to the QRS. So look for the B wave morphology and look for the axis of the B wave. After you decide this is SVT and you have seen the B wave, look at the relation between the B wave and QRS. Is it a short RB or long RB tachycardia? So these are some examples of short RB. Short RB is AVNRT or AVRT, and long RB is sinus tachycardia, sinus node reentry, and atrial tachycardia, and very rarely atypical AVNRT and AV. Actually, atypical AVNRT, still it's in the short RB, but more than 60. Here in the short RB tachycardia, how would you differentiate between AV modal reentry and AV reentry tachycardia? It's by the RB itself. So in the AVNRT, usually it's very short, less than 60 millimeter. AVRT usually it's more than 60 millimeter. So it is a short RB, but the distance is the difference. So this is another scheme again to build up your approach. So if you said this is narrow complex tachycardia, is it regular or no? It's not regular. You will be thinking about atrial fibrillation, atrial tachycardia, flutter with variable block, or not. If it's regular, try to localize the B wave. There is no B wave, you will be thinking of AVNRT. If you have B wave, try to see the morphology of the B wave, the axis of B wave, and was it greater than the ventricular or no? So if you have a B wave more than the ventricle, at that time you think of flutter and atrial tachycardia. If not, and then you go and analyze the RB, short RB or long RB. So we will come to all of this. I know it's confusing when you read it like this, but we'll apply it now in ECGs, and we take it step by step, and inshallah it will be easy. So we'll start now the interactive part, the ECG cases. So we'll take The first ECG. Who will volunteer for the first ECG? Dr. Suhair, you want to start?
Yes. It is a narrow complex tachycardia. There is narrow complex, irregular. The rate is about 170. There is no obvious P wave. Most likely the diagnosis is atrial fibrillation.
Atrial fibrillation. طيب sure ما في أي P wave. If you look.
No obvious P wave. طيب دي في V1.
V1, okay.
في inferior lead there is
Here, what do you think about this?
there is P wave.
This. So there is B wave, but it is a different morphology, right?
Yes, there is P wave.
So B, there is B wave, and for each P you have one QRS. For each P you have one QRS. So 1-to-1 is the conduction. And the B wave is not of one morphology. So you have B here, you have B here, you have B here. Which
different in morphology.
Yes, more than 3 morphologies. So
most likely atrial tachycardia.
Atrial tachycardia only or multifocal atrial tachycardia?
Multifocal atrial tachycardia.
Multifocal atrial tachycardia, excellent. So this is the B wave?
Different shape of B wave in the inferior leg.
Yes, we have different B wave morphology, and then it's irregular here. طيب, who will take this? دكتور مصعب أو دكتورة سارة؟
Yes, this is wide complex or mixed narrow and wide complex tachycardia. You hear me?
Narrow complex?
And wide complex also.
Okay.
It looks irregular. There is in the narrow complex, there is a P wave.
P wave. Which lead?
Lead V4,
V4,
V5, and V6.
Okay. The P wave here. This P wave.
Inverted.
Okay. Inverted P wave. Okay.
In the wide, in the lead 1, 2, 3, AVL and AVF, there is a wide complex, and I don't see clear P wave.
See here, settle P wave here in V1, sir.
V1, yes.
Yes.
After the QRS immediately.
Yes, here.
There is P wave.
Right. هو يعني most of the time, most likely this is one rhythm, one tachycardia, one diagnosis. It's very unlikely إنه يكون مثلا one type of arrhythmia here and this second type of arrhythmia here. So what do you think the arrhythmia? سواء هنا أو هنا. So analyzing, start هنا, we said that this is narrow complex tachycardia, right?
Yes.
Right. And there is wide complex here. So first question comes to you, why is this wide here and why is this narrow? Okay. Is there any change for rate?
And the rate, yes.
Yes, the rate here is very fast. So this is most
300.
تقريبا.
And in the narrow, around 170.
Yes. فهنا most likely rate لأنه once the rate slow down, QRS went back to its baseline.
It is normal.
So this is most likely rate related thunder branch block. يعني هنا at this point, so you will not think of ventricular tachycardia or other causes of white complex. So this is most likely rate related tachycardia لأنه it was wide. Once the rate slowed down slightly, immediately the QRS went narrow. Okay.
So it is aberrantly conducted.
Yes, conducted due to rate.
طبعا ناداني ولما تذكرت جيت راجع عليك لتليفونك.
المايك.
شكرا.
دكتورة سهير.
ولا معلش.
دكتورة سهير في ميكروفونك.
طيب let's continue. الآن احنا we analyze إنه this is narrow complex tachycardia. Okay, and this wide is only because of aberrancy, should not affect our diagnosis. So we have narrow complex tachycardia. The next step for narrow complex, are there any B waves ولا لا؟ احنا we were able to see a B waves هنا, and we were able to see B wave هنا as well for V1. Okay, so هنا 1, 2, 3, we have 3 B waves هنا for 1 QRS. So في some sort of plot يعني 3 to 1.
3 to 1.
And هنا we have 1.
يا دكتور محمد خليل معلش ما ظاهر الحاجه اللي انت بتاشر بها الارو ولا ما في شيء ظاهر؟
الماوس ما ظاهر؟
ما ظاهر.
معلش خلاص اوكي. اوكي. So احنا we're talking about ال B wave 1, 2, 3. So this is 3 B waves صح؟ for 1 QRS.
ما ظاهر برضه، ما اعرف باقي الناس ظاهر لهم. ايوه كده ظاهر
واضح. ايوه
ظاهر. Okay. So we have 1, 2, 3B for 1 QRS. So this is 3 to 1 in this speed. Let's analyze another beat here. We have 1, 2B, then QRS. So for now we know and there is block, variable block. If we come here, it's 1 to 1. That's why the rate is very, very rapid. 1 to 1. We have B wave here, very small B wave, and you have QRS. So thinking الآن there is a B wave. Try to analyze the B wave. Your answer or your diagnosis will be in this B wave. Is it an atrial tachycardia? Is it atrial flutter? Or is it a multifocal atrial tachycardia? It is not sinus for sure, because of very rapid and because it's up positive in V1.
It looks atrial tachycardia.
طيب. It could be atrial tachycardia or atrial flutter. طبعا in real practice, this is always a dilemma. In EKCG, we say some people say this is atrial tachycardia, and some people say atrial flutter. This is the two overlapping diagnoses. How you can differentiate?
Excuse me, Saya.
Yes.
But regarding the atrial tachycardia, usually it's 1 to 1.
It can be 1 to 1, it can be 2 to 1, or 3 to 1. It's not a rule. The atrial tachycardia can come at any. Yes, the atrial flutter comes with more block لأنه the flutter is faster rate 300, so AV node is less likely to be able to conduct for a long time. لكن it's not a fixed rule. And we will have examples for ECG coming atrial tachycardia with block. So this is not a rule. You shouldn't exclude atrial tachycardia because of that.
Okay.
So when you are suspicious about these two, look at the isoelectric line. Can you elaborate any isoelectric line here? So here, let's go in the inferior leads. We have negative deflection, we have negative, we cannot see any isoelectric line, right? So go to V1. We cannot see any isoelectric line, but anyhow, this is very rapid. There is no even enough time to generate an isoelectric. Go to the slower rate here in the inferior. Again, there is no clear isoelectric line. This is typical sawtooth appearance, huh? Here.
Yes,
Yes, agree.
So this is supporting atrial flutter more than atrial tachycardia. Okay, so this is most likely atrial flutter, typical atrial flutter with variable AV block.
Okay. Excuse me.
أيوة تفضل.
Regarding V1, the last تقريبا the last 2 beats, I think it is not apparently conducted. It changes the isoelectrical line from negative to positive. This is BVCs.
You're talking about the QRS here?
Yeah.
QRS. QRS here, it's almost back to narrow. Slightly wideish, like it's not as wide as here.
you one of the that is apparently conducted.
BBC usually is very,
because
very
it change even the isoelectrical line from negative to positive. So this is usual with the
isoelectric line. And here we don't have isoelectric line. There is no clear isoelectric line. Or you mean a T wave?
طيب at least the QRS in the V1 is negative.
QRS here?
Yes, it's negative.
Yeah. It was still negative here but you have apparently here because the heart rate is very rapid. So here was apparently conducted. It gives you what is the most common bundle branch block for rate related is right bundle branch block. So here when the rate is very fast, gives you right bundle branch block. Intermittent, here a little bit slow down the heart rate. Notice the aberrancy disappeared for a while, and then again here aberrantly conducted, and then again back. So this is the baseline QRS. If you want to interpret the baseline, so this is the actual baseline QRS. So if you want to comment about Q wave, for example, here, if you want to comment about bundle branch block, here there is a P wave embedded here. So difficult for you to interpret the QRS. But it does not go with BVC because BVC is usually very wide, more wide than this, and it's bizarre shape. And you have a QRS that is bizarre and inverted T wave. So this doesn't really go مع ال BVC. Well, BVC, the other thing, comes premature, so it comes earlier. All of these things doesn't go مع ال BVC.
Okay. Thank you.
Next ECG, who will take this?
What about the axis?
Axis, okay. طيب الأكسس here هو منو اللي فعل الأكسس؟ Axis.
Yeah.
طيب.
Right.
What do you think? Why? الأكسس هنا ال AVL is negative وال AVR is positive. ال AVF is positive, right?
Yes.
لكن this is not enough to say right. You have to look at lead 1 back there. فهنا lead 1 is positive, so this is normal axis. Yes, it's toward the right, but it's not right. This is normal axis. الأكسس طبعا you have to memorize the circle حقت الأكسس and you have to know which leads. Normally, if you want to know the axis by number, you have to look at AVL and AVF because these are the limits of the axis. السيركل حقت الأكسس دي if you notice the normal axis start من AVL اللي هي minus 30 up to AVF which is positive 90. So you have to look at these and these are the borders. You cannot say look at 1 or 2 or 3 only. Okay?
Yes.
طبعا this is different. احنا ممكن we have another session about the axis. We can talk about it in a different in another session. And it needs illustration, it needs drawing, and it needs to explain it further. And a lot of people actually get confused about the axis only by these two, and they can give a lot of people will mistaking this as the right axis. طيب I will take this. Dr. Ahmed. دكتور احمد ودكتور مصعب. Any volunteer 5 minutes. دكتورة سهير قد واحد.
This is a narrow complex.
Okay.
Tachycardia, the rate is about 100 or 98. There is P wave, every P wave followed by QRS complex. So the diagnosis most likely is there is fluttering wave in the inferior lead.
Lead 2? Lead or 3?
Lead 2 and AVF.
Okay.
Most likely atrial flutter with 2 to 1 and 3 to 1.
Atrial flutter. طيب. Why you said no fluttering wave? Fluttering wave usually doesn't have isoelectric lines, huh? So here we have especially in the inferior. So but when you commit an isoelectric, look at the inferior lead. But here we have isoelectric line here, and we have isoelectric line.
So it is atrial tachycardia.
So it is atrial tachycardia, exactly correct.
Atrial tachycardia.
Yes. So exactly as we said in the narrow complex tachycardia, we have P here and P here. So we have 2 P waves for each QRS, right?
Yes.
So this is B and this is B. You can trace it down and you can follow again. For V1, it is negative here. Okay. So this is atrial tachycardia, and to complete the diagnosis with 2 to 1 AV block. But you expect the atrial focus here to be for left atrium or for right atrium?
In left atrium because of the negative P wave in V1.
For left atrium because of negative V1. طيب left usually into V1 is on the right side. Correct? If it's in the left going toward V1 it will be positive. صح؟ this is most likely قريبة للساينس. احنا ال V1 في الساينس wave بتكون down negative ال B في الساينس. But this is somewhere in the right atrium near the sinus because it's negative here. It is positive here. Like, and it's not clear in lead 3. Okay. So
yes.
Most likely it's the atrium. Anyhow, it's not important to localize. Yani. This is a bit advanced. So this is, as you said, atrial tachycardia with 2 to 1. This is the B waves here. Okay, and 2 to 1 conduction. طيب, who will take the next? في هواوي من هواوي. Okay.
Atrial rate is 300. Am I right?
Mm-hmm. Yes, who was speaking? Dr. Suhair?
This is another complex tachycardia.
Okay.
The rate is about 110. There is no obvious P wave, but there is pseudo S wave in the inferior lead. May indicate retrograde conducted P wave, and so the diagnosis most likely AVNRT.
AVNRT. You mean this Q pseudo S?
I think so.
Yes. طيب, and then what happened? طيب, what do you think about this? You know?
There is a P wave.
Yes.
Obvious P wave.
معلش يا دكتور محمد، تاني البتاع ما ظاهر اللي بتأشر به، ما بيختفي، ما أعرف المشكلة شنو.
أنا أجيب القلم أحسن. دقيقة. أيوه تمام. أوكي. طيب احنا هي قالت انه this is pseudo S, right? So this is AVNRT, and then we ask what is this? معانا دكتورة سهير؟
Sorry, I didn't hear you.
طيب احنا you said انه this is pseudo S, right? في الليد 2.
Yes.
Pseudo S AVNRT. طيب what about this here?
This is retrograde conductive P wave.
Here?
I think it is retrograde conductive P wave.
But it's so far من الريتروجريد. You mean من هنا retrograde up to here? الريتروجريد here. This is retrograde. I agree with you. اللي هي pseudo R. This is retrograde P wave, which is pseudo R and pseudo S in inferior. But here, and this is B wave, which got blocked. This is back to sinus rhythm. If you notice هنا كان pseudo R and disappeared. There is no R wave here in the QRS. So back to sinus. And again, as we said, إن هي تكون abrupt offset. If you notice كانت AVNRT and abrupt onset B wave and then got blocked هنا. Probably either by adenosine or spontaneous. So abruptly stop and back to sinus rhythm. We support our diagnosis of AVNRT. إنه ال pseudo R disappeared and the arrhythmia stopped abruptly. So this is AVNRT. We'll take the next one.
Sorry, your voice is not off.
Okay, who will take this ECG next? دكتور مصعب.
ندي فرصة للشباب الباقيين احنا السنة.
خلاص nominate someone. مختار أو دكتور أحمد.
Okay, I can take it.
Okay, go ahead.
This is broad complex tachycardia, irregular. There is right bundle branch block. I cannot appreciate B wave, clear B wave.
Okay.
So my diagnosis, most probably this patient has atrial fibrillation apparently conducted.
Okay, طيب. Good analysis. اللي قلت هي wide complex tachycardia irregular, most likely atrial fibrillation as you said. And then you said إنه apparently conducted or right ventral branch block. Try to look closer يعني why it is wide. You see here something unique in this QRS.
طيب is there any delta wave?
Yes, exactly. The delta wave. You have delta wave.
Yeah.
and it's irregular. So this is atrial fibrillation plus WBW.
WBW.
Yes, delta. Okay. Next candidate, we'll take this. Dr. Zainab.
Hello, Assalamu alaikum.
Alaikum assalam.
Narrow QRS complex, there is a delta wave, short PR interval in lead 2 and lead 1. There is ectopic beat. Looks irregular.
Okay. طيب.
There is some
irregular.
Irregular, yes. There is some, I see some short PR interval.
Where is the short PR?
Lead 3.
Lead 3. Where is the B wave?
Second, fourth QRS complex preceded by short, yes. Lead 2. I mean, sorry, lead 2. Rhythm strip flow. In the fourth,
okay.
In the fourth QRS complex from the start. There is also ectopic beat. Some ectopic.
Try to localize LP. When you see something like LP, to make sure this is B or not.
In lead 2 rhythm strip, lead 2 fourth QRS complex.
You mean here? This one?
I cannot localize in lead 2. This yes.
Here.
Yes.
Right.
The second, yes.
If you follow it down the way,
there is B wave.
Yeah. Does it morphologically really look like a B, مثلا here or here?
Yes.
يعني this is similar to this, similar to almost the 3. And here it's up and here it's down. So it doesn't really look like a B. ممكن يعني suspicious. If you follow مثلا other lead هنا, there is no clear B, no clear B, no clear B. And then there is here again almost the same, but it's appearing 3-4 times here, and then appearing 3-4 times here. So this is most likely fibrillatory. This is the coarse fibrillatory wave because it's not organized.
Yes.
It's commonly
so
yes,
pre-excited atrial fibrillation.
Yeah, so atrial fibrillation here, and we have here one which is apparently conducted.
Yes, delta wave.
No, we don't call it delta لأنه delta is pathology. So this is normal. This is normal phenomena because the rate gets very small here. So we have here fast, slow, or slow and then fast, and then apparently conducted. And this is what we call it Ashman phenomenon.
Yes, okay.
Ashman phenomenon, rate conducted. So this is physiological, normal. It doesn't conclude any pathological disease. So this is, yes, atrial fibrillation.
Yes.
Beats here or Ashman phenomenon.
Okay.
طيب we'll take this. الدكتورة سارة في جالاكسي S8. And if you try to think or get it diagnosed before you analyze it, you get more confused. You can start to analyze it with loud voice. ما في مشكلة. Okay, any volunteer?
Yes, I can take it.
Okay, go ahead.
This is wide complex tachycardia.
Okay.
The rate is about 170. The axis
Right axis.
Axis, right axis, correct.
طيب. Wide complex tachycardia with the rate is of about 170. And there is this concordance with the chest leads, and there is a right bundle branch block pattern.
Okay. Hello, disconnected. طيب, anyone, any other for the volunteer to continue?
طيب, there is retrograde conducted B wave, which is very clear in the lead 2.
Lead 2, okay. Here, lead 2, retrograde.
Right bundle branch like pattern and positive.
Back, Dr. Sayed.
Positive. Okay. URS complex in the inferior lead, so it is superior axis. Superior axis and right bundle branch like pattern, most likely the foci from the.
Yes, why superior axis?
The LV.
How you say in the superior axis? By looking to AVR, right?
Positive.
AVR.
Positive R wave in inferior lead.
Yes, positive meaning that is inferior axis going down. Inferior.
Yes.
And superior lead will be positive in AVR. So this is right axis, correct? Like in not superior axis. So right axis.
It is from the LV apex foci.
Okay. So before we go to the what is the diagnosis to start with? يعني هل هو احنا when we say wide ايوه when we say wide complex tachycardia, it's either an SVT with aberrancy or VT, correct?
Yes.
So what do you think about
SVT with apparent conduction?
SVT with aberrant conduction. طيب, excellent. لكن why did you say that? What's your evidence في ECG انه this is SVT with aberrant?
عندنا الأكسس.
Okay.
Against LVT.
Okay. لأنه ال VT is not always superior. لكن okay, we'll take it مثلا as a one إنه الأكسس is right bundle.
Atypical right bundle branch block.
So what other than the axis? If you notice, when you get disconnected ورجعت احنا كنا عاملين circles على things here. What are these things? B waves, right? So this is B wave, small hump after the QRS, B, and it's there in all the QRS. So we have B. So there is no AV dissociation. So this is B waves, retrograde conducted B waves after the QRS. So most likely in SVT with aberrancy. What type of SVT? NRT, AVRT, atrial tachycardia.
AVNRT. لا orthodromic أي antidromic AVNRT.
Excellent. Antidromic AVRT. Excellent. Antidromic AVRT because it is wide. So it is antidromic. Orthodromic usually narrow complex tachycardia. So this is antidromic AVRT. It is a short RB tachycardia. To analyze it similar to the approach. So this is, we agreed no, this is SVT with aberrancy. So to decide, go to the P wave. It is a short RB tachycardia. So short RB, it's either AV NRT or AV RT. Okay.
Excuse me, sir.
Yes, go ahead.
Even the orthodromic, if there is bundle branch block and the bundle of his in the refractory period will be conducted aberrantly and will give us
Yes.
broad complex.
Yes, orthodromic طبعا انت to be also sure when the patient is diverted to sinus rhythm. Because I have your patient go to sinus rhythm, in case of orthodromic, you will have a baseline like right bundle branch block or left bundle branch block. Okay, so still you can, you're right, you said orthodromic, sometimes orthodromic can be wide in cases of conduction disease, and the bundle branch block is already diseased, even the sinus rhythm, or because of very rapid heart rate. When it goes very rapid, 300 or so, it might again go to aberrancy conducted.
Okay.
So this patient, this is the same patient, and this is his baseline ECG, okay, which shows again here the short PR and delta waves. Okay, so this is his baseline. So this is WBD and orthodromic because the delta wave is clear here in the baseline ECG. Right, who will take this ECG? دكتورة زينب. دكتورة زينب أو دكتورة سامة.
السلام عليكم.
عليكم السلام. Okay, go ahead, دكتورة زينب.
irregular arrhythmias.
الصوت ما واضح.
Irregular pattern with
دكتورة زينب بس معلش الصوت ما واضح، ما أعرف عندي أنا براي ولا.
ocular irregular tourism strip.
أيوه تمام.
irregular.
أوكي.
Irregular, no clear P wave, cannot see clear P wave.
What are these things here?
There is B wave in the V1.
There is B wave. طيب على ال B wave how does it look like?
2 P wave and 2 QRS complex.
So
There is, yes, there is P wave in the V1.
أيوة في B wave, and the B wave does it look sinus? The B wave morphology and axis. Being positive في V1.
Not sinus.
Not sinus. Okay. So the B wave here positive, and then immediately you have a differential. لما يكون عندك more than عندك non-sinus B wave. And here the B to B تقريبا almost 300 again. We have two either atrial tachycardia or atrial flutter. So at this time, you go to the inferior leads. And yes, analyze it. Hal you have an isoelectric line here or not? Again, inferior leads.
No.
So no isoelectrical line again. There should be a lot of noise. So, Sarah, mute.
No.
Okay. So back again. طيب اوكي we're saying انه في بي ويف في ال V1 which is positive.
Yeah.
It doesn't look sinus. So our approach thinking in either this is atrial tachycardia or atrial flutter. So when we go into an inferior leads here and look at the B wave to determine whether there is an isoelectrical line or no. So there was no any isoelectrical line, and we have a negative deflection here, which goes مع typical atrial flutter. And again, as you said, the block is variable. You have 1, 2, 1, and then here variable block. And you have here 3 to 1, 1, 3 to 1. So we have variable.
Yeah.
Okay. دكتورة سارة معلش if you can mute لأنه المايك فيه some noise في Okay. So atrial flutter again with variable AV block. And the axis here, so this is positive and negative, it's almost toward the left axis. يعني it's not, this is perpendicular على lead 2. It will be exactly minus 30 تقريبا. And if you want to continue and complete your recording, you have like a left bundle branch block here, wide QRS, and here EBS. So atrial flutter and left bundle branch block. Again, who will take this ECG?
Counterclockwise.
What's the
partial left bundle branch.
أتكلم عن ال ECG دي ولا السنة اللي فاتت؟ دكتورة سهير؟ طيب دكتورة إيمان؟ خلاص any volunteer.
This is a narrow complex tachycardia.
Okay.
With negative B wave all over.
Okay.
And heart rate about 170.
Mm-hmm.
So there is prolonged RB interval.
Prolonged RB. Okay.
So most likely atrial tachycardia.
Most likely atrial tachycardia. Excellent. So we have a B wave in a narrow complex tachycardia, as we said, but then we have a B wave, which is abnormal. negative in inferior leads, and long RB. If you try to localize where will be the focus, you can do it or not?
Yes. The focus from the LA.
LA.
It is negative
right.
in the inferior leads.
Mm-hmm. Look at V1. Inferior will show you whether it is up or down. Yani, if it's negative in the inferior, that means it's a low atrial. So it's almost near to the junction, the AV junction. So it's the lower part of the atrium because it goes away from the inferior leads. So if we have the atrium, it will be from low atrial rhythm. And then V1 will show you whether it's coming from the right or the left.
Yeah, negative.
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 Most
negative
likely
from
a low right atrium focus. Low right atrium. Excellent. So this is again elaboration of the B waves. Who will take this?
Sorry, I have network problem. It is multifocal atrial tachycardia or atrial tachycardia?
The previous one, atrial tachycardia. This one, this is atrial tachycardia because we have only one B morphology.
Yes, it is multifocal or atrial tachycardia.
Atrial tachycardia.
Yes.
To say multifocal, you need more than 3 morphologies. So here it is all the same focus, same morphology of the B wave in all the beats. So it is atrial tachycardia only. Okay. Who will take this? دكتور مصعب موجود تاخذ به.
اوكي السلام عليكم ورحمه الله. This for me there is no clear B wave.
Okay.
And most likely either junctional tachycardia because rate about 1 2 3 4 more than 70, most likely going with junctional tachycardia.
Excellent. So accelerated junctional tachycardia.
Yes.
Or junctional, correct. في any other finding في الECG دي؟
والله يمكن